Ladies and gentlemen, welcome to our Hong Kong Neuro-ophthalmology Distinguished Lecture Series. Because of COVID, our lectures have been postponed, and as you may know, this lecture series was conceived to engineer topics around 4 different themes, including community ophthalmology, beyond ophthalmology, ophthalmic education, and research advances. Our first lecture, inaugural lecture, was delivered by Professor Watson Lee, and he gave a lecture on the development of ophthalmology in Hong Kong, which was then followed by our second lecture, delivered by Professor Tony Mok from the Department of Clinical Oncology at CHK. He talked to us about how to design transformative clinical trials and is under the theme of beyond ophthalmology. And today we have our third lecture, which is under the theme of ophthalmic education, and we are very much honored to have a very distinguished panel with us. Our speaker here, we have Dr. Andy Cheng, and we also have 3 consultants in neuro-ophthalmology. So it's actually a very special evening here in Hong Kong where we have 4, I believe I can put it this way, 4 top neuro-ophthalmologists in Hong Kong. We have also Dr. Cheng from Hong Kong Eye Hospital, COS and consultant. And we have Dr. Nelson Yip from United Christian Hospital, and also we have Dr. Lowell Chen. Both of them are consultants in the Hospital Authority hospitals. And this lecture, we have 3 parts. The first part would be delivered by Dr. Cheng, which is followed by a Q&A, and then we also have a panel discussion on some cases. Dr. Cheng is our graduate, Hong Kong U graduates 2000, and then his first job in Hong Kong is in Hong Kong Eye Hospital, where he received his residence training before he went to the UK, Moorfields Eye Hospital and St. Thomas and Guy's, under the mentorship of Professor Gordon Plant for studying neuro-ophthalmology. And then he returned to Hong Kong, and now he is honorary consultant in Hong Kong Sanatorium and Hospital. So without further ado, let me invite Dr. Cheng on the podium, and then Dr. Chen, Carmen Chen and Will Chen can perhaps you can go back to the audience before joining our next section. So Dr. Cheng, please. Thank you.
Thank you very much, Chris, for your kind introduction. So good evening, everyone. I'm so happy that after all these years, finally I can see many familiar faces in person here. So firstly, I would like to thank Professor Chris Leung and the Hong Kong U Department of Ophthalmology for inviting me to join this lecture. It's my honor to be able to join this prestigious lecture series, and I'm very happy that I can be back to my alma mater. So as said by Professor Leung, today is on ophthalmic education on neuro-ophthalmology, and our topic I'm going to share with you today is on optic neuritis. And when you see one, what should you do next? So, you know, neuro-ophthalmologists, as usual, seldom have anything to declare. So now, when I started my neuro-ophthalmology training many years ago, and I find that the specialty of neuro-ophthalmology daunting as it's unlike other specialties. Now, when you see a cataract, it's a cataract. When you see a retinal tear, it's a retinal tear. And you know exactly what you need to do to help the patient. But when you see an optic disc swelling, it's a different story. You know that you still have many steps to go before you can establish the diagnosis and to administer appropriate management. At that time, I always ask Carmen, what should I do? And Carmen's always tell me that go back to the Bible of the neuro-ophthalmology, which are these 2 books. These two are the newest version, and I won't tell you the version that Carmen and I used at that time. Now, I diligently listened to Carmen and read up the books. And, you know, as a Star Wars fan, I felt like I was given a lightsaber. You know, I can be a master Jedi in neuro-ophthalmology. But in reality is that when I go back to the clinics, I just look like Finn, which, you know, accidentally pick up a lightsaber, can beat a few stormtroopers, but I'm nowhere like a master Jedi. So I was thinking to myself, what am I lacking to become master Jedi in neuro-ophthalmology like my mentor, Dr. Gordon Plant? And after some time, I realized that apart from factual knowledge, I need a proper approach to neuro-ophthalmological patients. And this approach is slightly different from ophthalmology, to seeing general ophthalmology patients. And that's why initially I find seeing neuro-ophthalmology patients a bit daunting. So my approach to neuro-ophthalmology after all these years is that whenever I see a patient, the first thing I do is to localize the lesion, and that's the most important thing. After you localize the lesions by the patient's clinical history or visual examination, the next thing to do is to generate a list of differential diagnosis. And usually with the location of the lesion in mind and with the background clinical history examination, most of the time you can generate a list of differential diagnosis, which guides you to a proper workup and ultimately to a diagnosis. But there's slightly difference in neuro-ophthalmology. Many neuro-ophthalmological diseases actually do not have a specific test. Like, for example, if you are PCR positive for COVID, you are having COVID. For neuro-ophthalmology, it's another story. Many diagnoses are of clinical diagnosis, like non-arteritic ischemic optic neuropathy. And that's why you should need to monitor the clinical progress of the patient and see the treatment response. And you see that the clinical response or the clinical progress is different from what you expected. You need to think twice whether you are having the correct diagnosis. And of course, in neuro-ophthalmology, we need many good friends. Our neurologists, neuroradiologists, and neurosurgeons are our good friends, which we usually work as partners to help us to manage our patients. So before I get to the main bulk, let's clear up some basic stuff. Now, neuro-ophthalmology is all about seeing patients with visual problems due to neurological disorders. And by that, we need to know what normal vision makes up. Now, normal vision depends on the integrity of both the afferent and the efferent visual pathway. For the afferent visual pathway is the sensory input from the retina to the visual cortex. And for the efferent motor pathway is the motor mechanism controlling the extraocular motility, like, you know, saccades to the target of interest, and then have a visual fixation without any nystagmus or saccadic intrusions, and then accommodate to focus on the object. And if problem arise in any of these, results in abnormal or poor visions. So the afferent visual pathway actually spans from the retina back to the visual cortex. So actually from the front to the back part of the cerebrum is involved. And for the efferent motor pathways, the signals arises from the frontal eye fields and the parietal occipital junction, send down signals to the midbrain and the brainstem centers of gaze centers, and then to the effector nucleus in the midbrain and the brainstem. It also receives signals from the medulla oblongata, which actually this shows that the whole part of the brain, from the cerebrum to the medulla oblongata, is involved in normal vision. So there's no doubt that many neurological diseases can have ophthalmic manifestations. So for today's talk, we'll focus on the afferent visual pathway, and mainly the anterior parts involving the optic nerve, optic chiasm, and the optic tract. So as said, today I'll talk about optic neuritis. Please remember the phrase. Optic neuritis is the most common cause of unilateral visual loss with an RAPD in young patients with normal fundus and a swollen optic nerve. So whenever you see this scenario, think about optic neuritis. Now, to prevent sending all of you here at this time of the day after a long day work to a state of symptomatic narcolepsy, I now try to present with cases to prevent, you know, too much factual information and send you all to sleep. Now, for the first case, it's a 44-year-old lady present with a left blurring of vision, no pain, and she attended our outside ophthalmologist and with FAICG and OCT macula told to be normal. Now, I first saw her with count finger vision over the left eye, left RAPD, no pain, and a normal fundus. So, optic neuritis picture. So, the lesion most likely is in the left-sided optic nerve, which this visual field shows the left side diffuse loss and the right side non-specific loss. So, as said, localization of the lesion, left optic nerve. So, this is the MRI brain of the patient. This is a T1 weighted FAST image. You can see that the left optic nerve is a little bit thickened over here with a contrast enhancement, which the coronal cut shows, better, showing the parenchymal enhancement of the optic nerve. So this patient have a left optic neuritis. And is it enough? Of course, the answer is no. We need the MRI brain. The MRI brain with this flare and T2 weighted image shows periventricular plaques here. And in the axial scan, you can see they are perpendicularly oriented to the ventricle, so the so-called dorsal fingers. So of course, the diagnosis is obvious in this patient, multiple sclerosis-related optic neuritis. So we admit the patients, give 3 days of pulse steroid of the patients, and you can see that the patient's vision slowly improves, which this is rather typical for MS-related optic neuritis. You can see in a moment, another patient, the clinical progress or the response to treatment is a bit different from this one. Now, this one is a bit classic for MS-related optic neuritis. The visual field at about 2 months is, grossly back to normal. So blood test, including aquaporin-4 negative, patient refused lumbar puncture, and we gave the diagnosis of demyelinating optic neuritis, multiple sclerosis related, referred to neurologist, start on teriflunomide, and the patients have no further clinical attacks for 4 years. So this is the first patient. So moral of this story, MRI orbit with contrast is very helpful to help us to confirm the diagnosis of optic neuritis. And whenever you see a patient with optic neuritis, remember, we must do an MRI brain because we need to exclude the possibility of multiple sclerosis. And do you remember this patient don't have any pain? And actually pain, if you read Western literature, is a very important symptom for patients with optic neuritis. But actually, we have demonstrated, with Carmen and Noel, that pain is not a prominent feature in us Chinese population. So remember, Chinese optic neuritis, pain is not a common feature. Okay, so our second patient is a 39-year-old lady, again, young patient, right blurring of vision, this time mild pain, admitted to a local hospital, CD brain and orbit with contrast normal, basic blood, FAICG normal. She was also told to have a right constricted visual field. When I saw her, the right eye, light perception vision, RAPD, mild pain, normal fundus. So again, optic neuritis picture. Localization of the lesion, the right optic nerve. So this is the visual field, diffuse right-sided visual loss. And this is the MRI. Now, remember, we said that the lesion is located at the right optic nerve. This is a stir image, and we can see that there is a T2 hyperintense signal over this part of the optic nerve, the intracanalicular and the intracranial portion. And that explains the poor vision because of the intracanalicular portion involvement. And this is the T2 weighted image. You can see that there is enhancement over the parenchyma of the optic nerve. So it is the intracranial portion. So diagnosis, right optic neuritis. So we admit the patient again, give her pulse steroid. The first day, the patient said that, oh, my headache is gone, and vision is greatly improved. You see, light perception to 20/80, which is different from the MS-related optic neuritis just now. Now, this is more typical of those inflammatory type of optic neuritis. So we continue the pulse steroid, and subsequently the rheumatoid factors turn out to be a bit elevated, aquaporin-4 negative. So the diagnosis is an atypical inflammatory optic neuritis. So because of this, we not only give the ONTT 2 weeks of pulse steroid, we slowly taper the pulse steroid for about 2 months, and the patient have no recurrence up to 4 to 5 years. So moral of this story, again, MRI orbits, important to confirm optic neuritis. And we Chinese actually have more the so-called atypical optic neuritis. And my mentor, Gordon Plant, always said that being a Chinese is already an atypical feature of optic neuritis. And of course, never assume optic neuritis are typical as in Caucasians. And we can see that the clinical course or the responsiveness to treatments can actually give us a hint of the underlying cause of the optic neuritis. So the third patient, 48-year-old gentleman, right blurring of vision, 2 weeks, seen by ophthalmologists, an MRI brain organized. But of course, MRI brain is not the gold standard for diagnosing optic neuritis. So the report says that it's suspected optic neuritis. There's no pain. Vision, count finger, right RAPD, failed color vision, no pain, and normal fundus. So again, optic neuritis picture. So supposedly the lesion is over the right optic nerve. But take a look at this visual field. Does it ring a bell? Noelle nod her head, so probably Noelle knows the answer. Now you can see that there's diffuse right visual loss, but the left eye, there's some temporal visual loss, temporal field loss, especially over the supratemporal region. So this is a junctional scotoma. So where's the lesion? It's in the posterior optic nerve and the anterior chiasma over the right side. So we did an MRI. We noticed that this stir image, there is thickening of the right-sided optic nerve posterior and the involvement of the anterior chiasm, and which is better shown in the contrast scan. I can't move my cursor. Yeah, down below here. So this is the coronal cuts. We can see that the posterior part, the intracranial optic nerve is enhancing and involving the anterior aspect of the right optic chiasm. So remember this patient, chiasmitis, involvement of the chiasm. So be careful of this type of optic neuritis. But still we admit the patients, pulse steroid, and I was called on the first day. The patient developed hiccups after the first dose of pulse steroid. I prescribed Lacactil to him, but seems that the patient still complains of hiccups. So does it ring a bell? So the next day, I bring the films to our neuroradiologist, and we particularly look at the medulla oblongata. And finally, we find this tiny little T2 hyperintense lesion over the dorsum of the medulla oblongata, which actually corresponds to the area postrema. So chiasmitis, area postrema involvement, the most likely diagnosis is NMOSD, even before the availability of the blood test results. We know that this patient is likely suffering from NMOSD. So we continue the pulse steroid, and at week 1, the vision is still 20/40. We start to discuss with patient whether he wants a plasma exchange, but before that, his subjectively visual is recovering, so he turned us down, and after 2 weeks of steroid, his vision is back to 20/20. This is his visual field at about 1 month. So subsequently, the anti-aquaporin 4 antibody positive, we started him on azathioprine. This patient is seen by me a few years ago. If nowadays, probably I will start mycophenolate or rituximab. MRI spine normal, and the diagnosis NMOSD-related optic neuritis. So why is it important to diagnose NMOSD? Because if left untreated, it carries a high morbidity and mortality. Apart from visual loss, of course, spinal cord involvement can cause paraplegia, quadriplegia, or even brainstem involvement can cause respiratory failure, which carries a very high mortality rate. So acute treatment, intravenous methylprednisolone. If rod responds well, we have rescue therapy of plasma exchange or IVIG. And for maintenance therapy, nowadays we usually go for mycophenolate or rituximab. We also have very limited extreme experience of satralizumab, but we don't have experience of eculizumab and inebilizumab. So moral of this study, whenever you do a visual field, please remember to do both eyes. Sometimes the patient complains of the right eye visual loss, but actually, in this patient, but actually the left eye also have a temporal field defect. So remember, for all neuro-ophthalmological patients, do visual field in both eyes. Always remember NMOSD in non-Caucasians population. And actually, we have done a study demonstrated that 4% of Chinese patients present with optic neuritis picture are actually NMOSD. And actually, this is in congruence with another study done in Tongren Hospital by Jiang Xiaojuan. She also did about 3 to 4% of the Chinese patients present with optic neuritis picture are in fact NMOSD. And for all optic neuritis, apart, looking for the blurring of vision, the visual field, do remember the associated features like hiccups, symptomatic narcolepsy, or other features suggestive of myelitis. So the fourth patient, a 24-year-old lady, complained of right blurring of vision for 1 week. Some pain, MRI done outside showed right-sided optic neuritis, started on 3 days of pulse steroid, and then a slightly lower dose and a relatively shorter duration of oral steroid, and then stopped. And she noticed blurring of vision again over the right eye 3 days after stopping the steroid. So best corrected visual acuity 2300, right RAPD, poor color vision, right eye, no pain, no swelling. Again, optic neuritis picture. So likely the lesions, again, in the right side optic nerve. So the visual field, diffuse right visual field loss, so most likely still the location is the right optic nerve. And this is the similar, I must say this MRI is not exactly for this patient, but it's pretty similar. Now, we can see that this MRI shows in the stir image here, there is a donut sign and dirty fat sign. We can see that there's a rim of T2 hyperintensity around the optic nerve, and the surrounding fat shows streaky T2 hyper enhancement. And the contrast MRI on the right side also shows thickening and dirty fat sign. So these clinical pictures of in MRIs suggest the diagnosis of optic perineuritis. So for her, we resumed the steroid 40 milligrams, that means 1 milligram per kilogram for 3 weeks, and then we slowly taper and give a longer course of about 3 months steroid. Vision gradually improved, and the visual field back to normal. So blood workup, all negative. I admit at that time I didn't take blood for the anti-MOC, the myelin oligodendrocyte glycoprotein antibody, because at that time it's not available, it's a few years back. And nowadays, if I see optic perineuritis picture, I'll definitely take the anti-MOC antibodies. So, moral of this study, always review the MRI whenever there is atypical clinical features or when the clinical course is deviated from what you expect. Again, do not assume all optic neuritis are treated the same. ONT, multiple sclerosis-related optic neuritis, you can treat for 2 weeks, but most other optic neuritis, sometimes you need a longer course of steroid. In Hong Kong Chinese, again, our study demonstrated optic perineuritis make up about 14% of patients presented with, again, optic neuritis picture. So do remember, it's best to review the MRI film yourself or with a neuroradiologist. So it's our 5th case. 45-year-old teacher complained of right blurring of vision, pain on EOM, seen by private ophthalmologist, noticed bilateral swelling, BP a bit highish, slightly obese, and she was referred to neurosurgeon for suspected raised intracranial pressure. She was admitted to the hospital, MRI brain, MRA, MRV were normal. Lumbar puncture 19. She was given Diamox, and at this time point, we were consulted because they realized that it's not elevated ICP. So when I first saw her, right eye vision count finger, left eye 20/20, right RAPD, pain, and this time bilateral swelling. Now for bilateral swelling, this is the finding for bilateral swelling, no signs of hypertensive retinopathy, LP still shows a normal ICP, so the most likely location of the lesion is still the bilateral optic nerves. So this is the visual field. Right side the diffuse loss, left side the constricted field. So do you know what investigation is left? Sometimes neuro-ophthalmology can be easy. You just screen through what investigation has been done, and what has not been done, you do it and you will get the answer. And that's the easy part of neuro-ophthalmology. So we did an MRI orbit. So you can see that there is, in this third image, there's a T2 hyperintense signal over the parenchyma of the optic nerve, and you can also T2 hyperintense signal around the optic nerve here, which similar to the optic perineuritis picture. And you can see some a little bit dirty fat sign. And this can be better shown in this contrast film. The right side, the optic nerve parenchyma is enhancing, and for the left side is the rim of the optic nerve enhancing. And you can see also this streaky enhancement, which called the dirty fat sign. So bilateral optic perineuritis picture. Oops, sorry. So we admit the patients, again 3 days of pulse steroid. And when we first give the steroid, only 1 dose, the patient immediately, a few hours later, told me that her headache is much, much better. So after 2 days of pulse steroid, actually the headache has gone. And the visions gradually improved in the first week. So the steroid responsiveness is pretty good in this patient. So of course, again, as said just now, with the optic perineuritis picture, bilateral involvement, we need to think about the MOGAD, myelin oligodendrocyte glycoprotein associated disease. And actually, these patients turn out to be positive for anti-MOC antibodies. So the diagnosis is MOGAD. And actually, this is pretty classic for MOGAD disease in adults. So this is the visual field, which is much better than before treatment. So moral of this story, MRI brain is actually not adequate for diagnosis of optic neuritis. You need an MRI orbit with contrast. And bilateral simultaneous optic neuritis is actually an atypical feature for typical optic neuritis. It's an oxymoron, atypical for typical optic neuritis. For all optic perineuritis picture, do remember to check the anti-MOG antibodies. So, still awake, that's good. So the sixth patient, still have 2 patients to go. I'm sorry for the long duration of talk. Now, the sixth patient is a 45-year-old lady, right blurring of vision for 8 months. And there is still optic disc swelling at this point. Do you think the clinical cause is, of course, previous CT brain and orbit with contrast normal, she was being labeled as optic neuritis, treated accordingly, but the optic nerve swelling and the blurring of vision is still there. Do you think that this is compatible with a classic optic neuritis? The clinical cause is deviated from what we expected, so we need to work the patient up. And when I first saw her, vision slightly impaired 20/30, right RAPD, slightly slowed color vision, and there's optic disc swelling like this one. A little bit, optic disc swelling, and there's a optic disc hemorrhage. As said, what has not been done, we do it, we will get the answer. This is the visual field, and when we do an MRI orbits with contrast, we can see this tram track sign. So actually, this is an optic nerve sheath meningioma. So we refer this patient for stereotactic fractionated radiotherapy, which she received 52 grades, and the disc swelling resolved and results in an optic atrophy. Vision stabilized in the past 3 years. So again, for all neuro-ophthalmological patients, you need to see the clinical cause and the treatment responsiveness. Many times with the clinical response, you need to revise your diagnosis and the management. So the last patient, 49-year-old lady, present to us with an acute onset, painless, inferior visual field defects. Seen by private ophthalmologist, she was told to have a right optic disc swelling, and the private ophthalmologist organized a MRI brain and orbit with contrast, which shows no features suggestive of optic neuritis. When I first saw her, vision, left eye slightly impaired, left RAPD, slightly showed color vision, left optic disc swelling, which I'll show you in a moment, and there is no other orbital signs or GCA signs. So this is the clinical picture. So the left eye, of course, you notice that there is a disc swelling, disc hemorrhage. But what is important in this case is the right eye. What is important? What do you see in the right eye? It's a crowded disc. It's a disc at risk. It's a small clubber's disc. Even in young patient, this 40-something-year-old lady, acute painless visual loss, this at risk. MRI showed no features of optic neuritis. You need to think about NARN. This is her visual field. We reviewed the MRI films with our neuroradiologist. We confirmed that it is a well-done MRI orbit, and there's really no features of optic neuritis. And when you see a patient with a completely normal MRI orbit, and it's of a good quality, think twice before you give the diagnosis of optic neuritis, because studies have shown that if a properly done MRI orbit with contrast, the sensitivity of detecting optic neuritis should be around 94%. And this study was done in 2002. Now it's 20 years from now. MRI has advanced a lot from that. And I do very believe that the sensitivity of MRI to detect optic neuritis should be much higher than 94%. So if the MRI orbit's properly done, no optic neuritis, do think twice labeling this patient as optic neuritis. So we work up this patient along those vascular risk factors. We found that this patient had undiagnosed hypertension and hyperlipidemia. So we refer to the family physician for treatment of these vascular risk factors and start her on aspirin. So workup all negative, clinical diagnosis, NARN. And I discussed with the patient whether she wants a course of oral steroid as per the Hay-Rays protocol, but the patient denied the treatment. So at month 3, the vision stable, no further deterioration, and this is her visual field, which is pretty similar to that as presentation. So lesson to learn. Diagnosis of NARN is a clinical diagnosis. You need a history which is acute painless onset of visual loss. Classically, it's altitudinal visual field defects. The patient should have a vascular risk factors, DM, hypertension, ischemic heart disease, and smoking is also an important factor. And obesity, snoring, obstructive apnea, sleep apnea is all other risk factors. And remember to look at the optic nerve morphology. The fellow eye will give you hints because the affected eye is swollen, sometimes it's a bit difficult to assess. The fellow eyes do give you hints of the diagnosis. And again, think twice to label a patient as optic neuritis if the MRI orbit, which is properly done, is normal. So what do all these cases that we discussed just now tell us? We can see that if we use a systematic approach to approach our neuro-ophthalmological patients, actually it will help us to better manage and quicker to arrive at a diagnosis and start to appropriate management. And of course, the topic today is optic neuritis. Do remember the phase that I said just now. Young patients, unilateral visual loss with the RAPD, normal fundus or diswelling, remember optic neuritis. Again, the systematic approach is that we localize the lesions first. And then with the clinical history examination, usually you can generate a list of differential diagnosis. Work up the patients, start the treatment, and remember to monitor the progress. Like the patients with optic nerve sheath meningioma, is actually the clinical progress or the response to the treatment help us to deviate the diagnosis back to the normal track. For all optic neuritis, MRI brain and orbits with contrast is the gold standard if available. And of course, usually we also need blood tests and sometimes electrodiagnostic tests to help us. Do remember the difference between the optic neuritis in non-Caucasians and Caucasians. The literature we usually refer to are mostly for Caucasians, and we non-Caucasians as Chinese are different from them. Do remember all patients with optic neuritis do look out for other clinical features like the case of NMOSD. Of course, life is not that easy. Just now we see 7 cases of various optic neuritis, but these are the list of other differential diagnoses that I have seen over the past few years with patients referred to me of suspected optic neuritis. All kinds of bizarre optic neuropathy and retinal disease can mimic optic neuritis. And of course, we are there to help, and hopefully if you have any problems, please allow us to help you to arrive at the diagnosis. So last but not least, I want to use some time to advocate our group. We do have a small society, Hong Kong Neuro-Ophthalmological Interest Group, which we established in 2020, and Carmen is now our convener, and we are very happy to have Dr. Miller and Dr. Plant as our advisors. And Dr. Umapathy, which will be our coming commission trainer in February, will be our commission trainer. He is a neurologist, and I listened to his talk a few times. He's just like a walking encyclopedia. He seems to, very, very interested in neuro-ophthalmology and very familiar with all kinds of topics. So please, if you are interested, do consider to join our groups. And actually, our last meeting in the last month, and we invited Professor Andy Lee from United States, and he talked to us on the disease called the SENS, Space Flight Associated Neuro-Ocular Syndrome, which is completely new to all 3 of us. It's the first time we know of this disease. So do consider to join us or join our later academic meetings. We hold regular academic meetings about 3 to 4 monthly. So thank you very much for your time.